should help some of you. All right, the last and the remaining topic on the back involves the musculature of the back. I've made the distinction on prior occasions between intrinsic and extrinsic muscles. We've talked about intrinsic and extrinsic muscles in the tongue, for example. With respect to the back, intrinsic muscles articulate the back, articulate the spine. Intrinsic muscles of the back, we're going to call them erector spinae for the most part, are the muscles that have a couple of things in common. Number one, they flex, extend, are responsible for rotation of the back and nothing else. Second, those muscles are all innervated by the dorsal ramus. Remember, that's a somatic ramus of each spinal nerve. So they're all innervated in more or less the same way by what's called the dorsal ramus, and they all share that common function of articulating the back. Now, extrinsic muscles of the back attach, in many cases, very firmly to the spinal column, but their primary function is not to articulate the back. Rather, their primary function, especially up top here, is to position the scapula and move the arm, move the humerus. So extrinsic muscles, while they attach to the spinal column, generally have some other function, such as moving the arm or scapula. Now, as I've indicated, I'm going to zip through this very quickly and just make a few very basic generalizations. Some of these muscles we'll talk about again as we talk about the upper limb, for example. So we've talked about the distinction between extrinsic and intrinsic. The muscles that you see listed in this AP revealed cadaver image here, the major muscles that you see would be extrinsic muscles. In one case, the trapezius is positioning the scapulae, the latissimus dorsi is going to be adducting and otherwise positioning the humerus. There are a number of these muscles. We've already talked about a few of these. For example, you know about the trapezius. The trapezius really anchors to the spinal column, but anchors not only to the scapula, but also to the clavicle. And depending upon the region of the trapezius we're talking about, it has rather diverse functions. But we consider them a superficial back muscle. The latissimus dorsi, we've indicated, very powerful, robust muscle, important in articulation of the humerus. We'll look at the rhomboid family here that lies underneath the trapezius, and then the levator scapulae muscles we've seen before with respect to the neck, and the term pretty much indicates what they do. Now, with respect to the trapezius, you already know the innervation. For all of these, I would want you to know very simply the attachments. You don't need to know insertions and origins, but you need to know the attachments. You need to be able to identify them, and you should know the innervation. The latissimus dorsi, again, adduction and extension, chiefly of the humerus, also serves some as a medial rotator. The nerve and the blood supply are both thoracodorsal. The two rhomboids, once again important, they derive their name from their shape, as you might imagine. These are also important for positioning the scapula, primarily retraction and elevation of the scapula, and the innervation is the dorsal scapular nerve. We'll look at that. We'll look at the little notch through which it passes later here.
I'm sorry, I'm confused. What's attachment be synonymous with origin and insertion? Like, can you give me an example of what you would want for us to know for attachment for this?
Yes. The origin and the attachment would not, or the origin and the insertion would not be the same. But in this case, you don't have to worry about it. All you need to know are the attachments between, for example, the trapezius, the spinal column, and the scapula and the clavicle.
So more like terminology.
Correct.
Okay.
Yeah. In general, I will not ask you in origins and insertions. It would just be a trivial use of our time and limited
So why is
weeks
it on
we
the
have.
side?
So again, the rhomboid minor, you can see the relative position of these two, major here, minor up here. Both are innervated by the dorsal scapular nerve, and both have similar effects on the scapula. Both very important in positioning the scapula for upper limb movements. The levator scapula does just what it implies. There's some, when we talk about respiration and physiology, it may also contribute to some extent to, as an external muscle of respiration. But its primary function is to elevate the proximal scapula. The innervation here is primarily, we'll just say, the cervical plexus. In the next two slides, you have reference to what are called intermediate back muscles. This is kind of a sort of factitious distinction. What it means is they're sort of intermediate in terms of their depth. We're looking at the two serratus posterior muscles. There's a serratus posterior superior and inferior. And the problem here is that frankly, we're not quite sure what they do. They're very, very thin sheets of muscle. You'll sometimes see that their action is being on the ribs. Frankly, they're probably too thin, too weak to have much effect on the ribs. Therefore, they probably do not play an important role in active respiration. We'll talk about what we mean by active and passive respiration later. Current thinking is that they're probably more sensory. If you've ever been in an old physiology lab, sometimes they'll put a sort of a bungee cord around the patient, and that bungee cord will stretch and relax as the patient breathes. And in that manner, the degree to which that bungee cord stretches can be read on a myograph and can be given some indication of the ventilation pattern of the patient. This is a very old way of measuring diaphragmatic and chest expansion with respiration. Current thinking is that it's probably what these serratus muscles are doing too. They're acting to monitor the degree of distension or stretching of the chest, and probably provide feedback information to the brainstem regarding the expansion of the chest. Now, I just want to spend some time talking about this structure down here, the thoracolumbar fascia, because this is going to be sort of the centerpiece of our discussion of the intrinsic muscles of the back, again, what we're generally going to be calling the erector spinae. So first of all, make sure you understand that this purple region down here is a broad, flat, tendinous sheath. We have used the term aponeurosis to describe these structures in the past. So this is a very robust, thick aponeurosis. And it's this thing right here. So in other words, once we clear away all of the integument and subcutaneous fat, maybe get down to the epimysium, we'd be looking at this layer. Let me show you again here, right there. So that's the exterior portion of the thoracolumbar fascia. Now I have to be careful here in any terms that I use to characterize this structure, because what you'll notice is the thoracolumbar fascia are a deeply investing fascia that does several things. All right, you can see that exteriorly it sort of circumscribes the extrinsic muscles, in this case the latissimus dorsi over here. So the thoracolumbar fascia would in effect function as the epimysium of the latissimus dorsi. But this investing membrane system goes out to the musculature of the lateral abdominal and abdominal wall. We're down in the thoracic region here. We'll talk about these muscles later, but I just want you to see, because these fascial membranes that you see here are also going to be very important in our discussion later. But probably most important, what I would have you pay attention to with respect to the thoracolumbar fascia is this membrane right here. See where I'm drawing that line there? Because that line separates the two portions, or the two divisions, of the intrinsic muscles of the back. So all of these muscles right here, and we're going to classify them as transversospinal and erector spinae. These are the intrinsic muscles, and remember their function is to articulate the back in some rotate, to flex, extend, lateral motion, and so on. Intrinsic, they're sometimes called deep back muscles. We'll just call them intrinsic muscles because that seems to serve the function. The transversospinals derive their name from the fact that really they just extend between adjacent transverse and spinous processes. In other words, the action is exactly on the vertebra. So they're kind of weak. Really, if you think about it, that's not a very powerful purchase for a muscle. The erector spinae, on the other hand, can extend from adjacent to, they can extend for a much farther distance, and as we move up the back, they also extend in some cases onto the ribs. So there's a somewhat greater mechanical purchase there. But in any case, I'm going to show you a picture in just a moment that clearly differentiates, at least anatomically, the transversospinals from the erector spinae. But what I want you to see in this context is how this thoracolumbar fascia sort of separates the two divisions. And for that matter, separates the intrinsic muscles from the extrinsic over here, from the muscles of the lateral abdominal wall, and from these very powerful hip flexors that we'll talk about later, the psoas and the iliacus. So this is the other illustration that I want you to pay attention to on the bottom right here. Oops. So the green are the transversospinals, and there are three of these. You need to know the names. Three names here: rotatories, multifidus, and semispinalis. These green are the transversospinals. And although it's not very clear from this particular illustration, what you should keep in mind is they simply extend between the spinous and transverse processes within each few vertebrae. By contrast, the erector spinae muscles, the purple muscles that you see here, and once again there are three general sets of these, the spinalis, longissimus, and iliocostalis, sort of spread out a little farther. And in fact, that's the way that we're going to differentiate them. What I want you to pay attention to is the fact that in these erector spinae muscles, the purple ones there, the spinalis are most medial, and the iliocostalis are most lateral. And in fact, you can see they're sort of attached to the rib there. They extend from the ribs on down to the vertebra. And then you can see in the intermediate with the serratus over here, and then here's our latissimus dorsi and vigus in relative perspective. So what I want you to gather from our discussion, make sure you know that if I were to show you a picture of the thoracolumbar fascia or something like this, be able to identify each of these components. I'm not so interested in you understanding the vertical relationship because it's impossibly, for the time we have, it's impossibly complex. You get some sense of it over here, although this is only a small portion of what we're talking about. But I do want you to understand the relationship of these groups to the thoracolumbar fascia and with respect to their position mediolaterally along the back, along the vertebra. So the little slide here is just pointing out the actions of the intrinsic muscles again, extension, rotation of the back. They tend to support the vertebral column, but the function of all these intrinsic muscles is simply to provide support and articulation for the adjacent vertebra. Now we're looking at the erector spinae here. We've already talked about the three general groups, and you can see all three groups sort of splayed out there along virtually the entire girth of your back, from medial to lateral. And again, they all have in common, they're innervated by the dorsal rami. So in the illustration here, again, I'm not going to ask you to sort out the particular attachment, but what you will notice, and this might be useful to keep in mind too, the spinalis, once again, more medial, the iliocostalis arrayed much more laterally with respect to the vertebral axis. And then in between are the longissimus. And then you also have the AP revealed images. Again, the iliocostalis are lateral, longissimus intermediate, spinalis right up and down those vertebral processes. The term splenius generally just means sort of flat band. And we're looking at the splenius capitis, which is considered one of the erectors. It's considered with the muscles of the back as an intrinsic muscle, innervated chiefly by the cervical plexus. And then you see the three groups of transversospinals. Please understand, I'm not going to ask you to tell me the points of attachment, but what they all have in common is that they attach between the spinous and transverse processes. They're not attaching to ribs or to associated skeletal structures. And thus again, they're kind of weak, they're not really very powerful. In fact, there's some debate about, for example, the levatores, which you can see sort of hidden in there. We didn't mention them. The reason we didn't mention them because we really don't know what they do. They're thought to be vestigial and thought perhaps to, again, serve a function, and a more important function in a quadrupedal animal. All right, and so know the terms of position and what we mean by flexion. By the way, in that illustration, which way is flexion? Is the individual flexed there? Okay, so just be sure you're not deceived by the illustration. And you can see the arrow showing the direction of flexion, the arrow showing the direction of extension. All right, when I finish, I know you don't have this slide. You don't have these next two slides. Doesn't that look comfortable? And the one we're going to look at in the actual procedure, it's even worse than this. This is called a Wilson frame. I want to finish up by looking at a video of discectomy. And the surgeon is going to take us through the steps. But as he does so, I want you to be thinking about the various tissues we've talked about in the back and how the surgeon must deal with each of those tissue layers to access what they need to work on. Remember, the objective here in a discectomy, the idea is that there's a herniated disc, and so a portion of the annulus is going to have to be removed, and then a portion of that nucleus pulposus is going to have to be removed. So the question is, how do you access that? For the lumbar region now, this Wilson frame is designed specifically for lumbar procedures of this sort. And usually it's designed to optimize imaging, so there's usually a fluoroscope. What's a fluoroscope? Yeah, and actually in many cases, not so much for this procedure, but for many fluoroscopic procedures, especially when they start working on the heart and so on. It's like an X-ray video. And of course, the patient is at some risk of radiation. The surgeon will make reference to a K-wire. Some of you are probably familiar with Kirschner K-wires. These come in all shapes and sizes. And so big, thick, it looks like about the size of the wiring in your house. And they'll jam it in at various points and places for two purposes, both to act as an index for depth, make sure that whatever instruments they're inserting are the proper depth. Sometimes they have little hooks on the end and so on. But they also use them to put serial dilators on. So you put the K-wire in and you watch him do it. Then he'll take concentric tubes, each one a little larger than the one before. He'll put the tube over the K-wire. Then he'll take another little pin larger than mine and put this over my pin. And then he'll put a little even thicker pin over that. Why would he do that? Yeah, to increase the size of the opening. I just wanted you to be aware of what you're looking at here. And again, I know you don't have this slide, but tell me, let's say this is our intervertebral disc. I mean, we're going to be at L4, L5, but it doesn't matter in the simplified illustration. Let's say it's herniating posteriorly. Of course, this is going to be our vertebral canal, the spinal canal here. How are you going to access it, and what are the problems you're going to confront? Anybody have any thoughts on the topic? All right, so a laminectomy would imply removal of the bone, the spinous process, perhaps portion of it. So you're right, we don't know yet, we'll just have to see. Probably it's not gonna be as clean and direct as this image would suggest. We'll watch him do, he'll have to cut away a little bone. In fact, he probably, I think in the video, he has to cut away some of the lactopsil joint too. What else do you see has to be has to be traversed to get to that herniation? Yeah, he's gonna have to deal with the yellow ligament there. All right, remember the disc is over here. You've seen the other problems. Yeah. Not only the spinal nerves, but the spinal cord. So you might be interested in watching how he deals with that, because remember, we're concerned, we really don't see it here, but we're concerned with impingement upon that intervertebral foramen. So this is a microdiscectomy. It could be worse, I guess.
Symptomatic disc herniation is a common indication for spinal operations. The open microscopic discectomy has been the traditional method of addressing the pathology. But minimally invasive techniques are increasingly popular. Advantages of the MIS microdiscectomy approach include decreased muscle and soft tissue disruption, shorter length of stay, and decreased postoperative pain. Here we demonstrate an MIS microdiscectomy.
So notice the age of the patient. This isn't an old person. This could be you. By the way, radiculopathy, does that mean this is just a silly disease? What is radiculopathy? Yeah, yeah, some problem with the roots there. Remember, the radicals are the roots here.
On a 24-year-old female with a left elbow.
Can you see it? Yeah, everybody see it there?
Or radiculopathy secondary to a large L4, L5 disc herniation. The patient is positioned prone on a reverse cervical bed on a radiolucent Wilson frame, and all pressure points are padded.
The radiolucent just means that it's a video x-ray. They're monitoring fluoroscopically what they're doing to make darn sure they don't put something in the wrong position.
Appropriately. The Wilson frame should be adjusted to flex the lumbar spine in order to optimize interlaminar access. The arms are abducted with the elbows flexed at approximately 90 degrees with the hands in pronation. Lateral fluoroscopy is utilized to localize the level of the pathology.
And this is why you need to know the anatomy. But notice how precise they're being with the anatomy.
Under fluoroscopy, a 22-gauge spinal needle is introduced into the paraspinal muscles, approximately 1.5 centimeters lateral to the midline, and adjusted until it is directly over the targeted disc space. Using a number 15 scalpel, an incision is made extending to the subcutaneous tissue above the fascia. A K-wire is inserted under lateral fluoroscopy toward the L4 lamina. Care must be taken to place the K-wire just past the fascia, but not too deep or medial, in order to avoid inadvertent entry into the spinal canal.
Which could be catastrophic, but you see what he's doing. This is his probe. He's making darn sure that he's feeling the bone and connective tissue as opposed to something softer and potentially more vulnerable.
Confirmation via palpation of bony integrity is essential. Serial dilators of increasing size are placed over the K-wire and docked onto the L4 inferior facet complex.
And there's the limiter they put on.
Lateral fluoroscopic image is obtained, confirming that the correct level is visualized.
Everybody see what we're looking at there? This is the pathology there. And you can see the position of the probe that he's introduced.
The operative microscope is then brought in for direct visualization of the field. The remaining soft tissues and muscles are
So for purposes of orientation, head,
dissected off the lamina and the transverse using bayoneted electrocautery until the medial aspect of facet joint is exposed. Once adequate bony exposure is achieved, the working channel is repositioned so that the laminar interspace can be visualized. Starting at the inferior aspect of the rostral lamina, a high-speed drill is then utilized to drill down to the depth of the ligamentum flavum.
So he basically burned everything off. He burned all the bony tissue, superficial tissue, and now he's using a drill to get down to the ligamentum flavum, and then you'll see what he does with that.
Once the ligamentum flavum has been identified, the bony removal is extended superiorly until the superior insertion point of the ligamentum flavum is identified and epidural space is confirmed by exposure of the epidural fat.
Almost using rongeurs to rip away anything that's in the way there.
To attain adequate lateral exposure, a small portion of the medial facet may be removed.
Acid.
The ball tip probe is then used to separate the ligamentum flavum from the undersurface of the lamina at its insertion. The ligamentum flavum is then gently dissected off of this insertion in a rostral to caudal manner and removed en bloc or in a piecemeal fashion.
So that's what this is. That's the ligamentum flavum there. And he's slowly going to remove that.
Using the Kerrison rongeur.
Are you impressed with the precision? Because it's not going back.
The pedicle of L5 is identified, and a nerve root retractor is used to gently retract the traversing nerve root medially to identify the disc space. The ball tip probe is then used to bluntly separate the ventral surface of the fecal sac from the disc space.
The fecal sac is everything inside the dura mater. So when he talks about being shell, it'll come up later in our discussion of reproductive physiology. So by fecal sac, he's talking about the dura mater, and of course we're in the lumbar, the caudate chyna, everything contained in it.
Using a nerve root retractor, the fecal sac and nerve roots are generally retracted medially
Push
and
them out of the
protected
way.
while bipolar cautery is utilized to cauterize the epidural veins overlying the disc space.
So what are we looking at now? He's moved the spinal canal out of the way, and now this white thing back here that we're looking at is what?
Posterior lateral.
That's the annulus fibrosus of the disc. And so now he's going to get ready to cut that, and this is when all the excitement begins. As if you weren't excited enough.
Next, a cruciate incision is made utilizing a bayoneted disc blade
Soft
that
bit, you
extends
might-
through the annulus fibrosus while attempting to avoid disruption of the underlying nucleus pulposus. Gentle downward pressure utilizing the nerve root retractor often
pushing
helps
right
to
to the
deliver the
bottom.
herniated disc fragment out through the annular opening. The pituitary rongeur and an angled curette
And
may
there she
be also
comes.
utilized.
Wow.
That was the annulus, and this is the piece of the pulposus that was obtruding.
The ball tip probe, or Woodson instrument, is then utilized to confirm the adequate decompression of the fecal sac, nerve roots, and neuroforamen.
This is the part that troubles me. I mean, I just brought the spinal matter back over the disc.
The cervical site is copiously irrigated with antibiotic irrigation. Meticulous hemostasis is obtained.
Apparently critical to prevent infection and problems.
Methylprednisolone solution is then irrigated into epidural space. This is optional. The working channel is then gently retracted, and small pledgets of gel foam are placed along the deeper aspect of the tract to maintain hemostasis. The incision is closed in a layered fashion. Obicral sutures are utilized to close the fascia in a watertight fashion. Inverted 3-0 microsutures are utilized to approximate the subcutaneous tissue and epidermis. Sear strips are utilized for the skin approximation.
You can see how small
incision.
small it is anybody troubled by the ending there?
I had a question. So did he remove the nucleus, or
I'm sorry?
did he remove the nucleus, or?
Remember, in a herniation, there's some type of, the annulus is compromised, so it's bulging because the nucleus is bulging, forcing
Right.
it. So he knew where that bulge is, so he cut the perimeter of the annulus where that bulge is, and there's already pressure, right? There's going to be mechanical pressure. He increases the pressure, that's what I was saying, he's pushing on from above. It pops through, he cuts both out, and then what?
Yeah, he didn't put anything back.
And I'm not a neurosurgeon, but I've watched a lot of these, I play one on TV. I've watched a lot of these procedures, and I gotta tell you, they don't do a lot of putting things back. So I'm not sure what to tell you, but in virtually none of the procedures that I've looked at, even the laminectomies, oftentimes that's not a primary concern. In some cases where mechanical reinforcement, especially in the back, where they have to put in metal and so on, it's a different story. But for a procedure like this, well, it's just cut and sew. Any case, I'm not an expert on the procedure. I just wanted you to make sure you understood and were appreciative of some of the anatomical issues there. All right. Burst fracture.
Ooh.
Everybody always jumps. It's a combination. That's why they call it a burst fracture. Other than that, there were two little segments here on myelography and discography. I'm going to skip over them. Anybody know what I'm going to skip over? These are procedures that are sometimes used. What they do in some cases is they'll inject stains of contrast agent either into the intervertebral space or into the disc itself, and that will help them diagnose the problem. But I'm going to skip over them because they're not performed so much anymore. Anybody know why? Something you're going to learn about later. Insurance no longer pays for it. And so that tells you some extent to how medical procedures are determined in this country. And if insurance doesn't pay for it, it's not likely to be executed. We've talked about arthritic degeneration of the vertebra. Remember the uncus, the uncinate region around the lip, around the body of the vertebra. What you often get with arthritic degeneration is this osteophytic deposition, the deposition of bone spurs around the uncus. And of course, as this process continues, that limits mobility. It enhances stenosis, narrowing of the vertebral canal, and can also be associated with considerable pain. And the vertebrae themselves can be quite altered in their normal conformation. All right, and that's all. Any questions about the?
So to take out the disc, now nothing's there.
Well, he put in gel foam, and I don't know what to tell you there. I have asked several people about this. I actually went to a surgeon one time, and let's just say I wasn't very satisfied with the answer, but I'm not, having done all that, I'm not a sufficient authority to give you a definitive answer. But my impression is, having looked at dozens and dozens of these procedures of this sort, that no, it would create more problems. Again, don't confuse this with some type of reconstructive surgery where extensive bracing or metal is put in. But even in those cases, the soft tissue is not generally replaced in many cases.
Like, do you know if there is like a recurrence of injury? I mean, if you did any kind of injury and there was no,
I would think there would be increased risk.
Right back out, right?
Again, I think there would be extensive lifestyle modification following a procedure like this. Yes, sir.
Did they take out the whole nucleus pulposus or just the?
No,
part that was
just
bulging out?
just that little portion that you saw bulging there, and then right behind it came the infringing nucleus pulposus. Yeah, that brings to mind, we'll look at some other surgical procedures in which I can answer your question more affirmatively. For example, in a lot of joint replacement surgeries, the whole nest just comes out. Probably shouldn't use technical term like mess. All right, let's move on then to the lower limbs. We have limited time in here. So, as has been our custom, I want you to be sure you know the general terminology, some of the more or the less common terminology to describe regions of the lower limb. I've listed some of them here. The gluteal, of course, refers to the region, the posterior butt there. Femoral region refers to the thigh. Remember, when we talk about the lower limb, there's a distinction between the thigh and the leg. So the lower limb consists of the thigh and the leg. The leg is distal to the thigh. Everything distal to the knee is considered the leg. That's the proper use of the term. Talocrural is the proper term to refer to the ankle joint or the region of the ankle. We'll have some other terms to describe that. Of course, the bones of the foot have their own special terminology as well, the tarsals, metatarsals, and phalanges. Then we're going to begin with a discussion of the appendicular girdle, or the hip pelvic girdle. And we don't have a lot of time here to talk about kinesiology, but from your perspective as a PA, a lot of what you will be doing whether you work in an orthopedic context or some other context, there are all kinds of information, indications, and signs you can obtain from observing a patient's gait. Everything from an appreciation of any potential mechanical problems to even potential brain damage. Because there are certain types of brain damage associated with those motor centers we talked about in physiology that will change the gait. For example, individuals that elevate themselves very highly on their calves as they walk and so on can be a sign of central problems. But in terms of the mechanics of the pelvic girdle, it's important to understand that it acts as a marvelous gimbal. And by gimbal, if you've ever looked at the transaxle of a truck when you're sitting beside a large truck on the side of the road and you notice that the transaxle goes back to the rear wheels there, but it changes direction. It's something called a U-joint. Well, your hips enable your upper body to move in various directions. We talked about circumduction. And you can do that while you're walking, right? Walking or running. And so the hip is able to modify, make relative adjustments to the right and left side as you walk. As you walk, most of us put our feet. If you think about if you were building a robot, and you were building a bipedal robot, you can watch how most of them walk. They walk like this. I've walked like that for many years in grade school. And in part, that's because those robots lack this more sophisticated ability to elevate each side as we walk. And moreover, like the what's that, the Cayman, that device that you see at the mall cops ride? Yeah, the Segway, thank you. Your brain is acting like a little Segway too, because if you notice, most of you walk with your legs closer to the center than you would design the robot. And once again, that impedes your balance, but it affords a much more gentle locomotion. Your center of gravity remains pretty much in the same position as you walk. Your center of gravity doesn't go up and down as it would perhaps in a robot. And all of this capability is largely dependent upon the proper functioning of this pelvic girdle and its ability to make so many simultaneous movements in such a fluid fashion. You can see, I think we've talked about flexion and extension, so be sure you understand what we mean by flexion and extension of the hip versus flexion and extension of the knee. So we talked about this. This is hip flexion, but that's knee flexion, so they're actually in the opposite direction. We use a peculiar terminology to refer to movement of the foot. I don't know that I've ever found this particularly gratifying, but dorsiflexion, plantarflexion, dorsi, plantar. So that's the proper terminology. Again, up is dorsi, down is plantar. So plantar is the much more powerful movement. And then remember, we talked, I think, earlier about inversion and eversion of the foot. Really proud of my Innovate shoes. These are track shoes, very proud of them. But inversion and eversion. Now, what we're looking at here are some terms related to the surface anatomy. These are palpable features of the lower limb, you are going to spend a lot of time using the iliac crest, this crest right up here, as an anatomical marker to let you know, for example, where certain intra-abdominal structures are located. So you want to make sure you are very familiar with the iliac crest. We're going to talk about the anterior spine and the posterior spine of the ilium. The ischial tuberosity is the thing you used to fall on when you were in grade school, and when the bad boy or girl pushed you and you fell down on the hard floor, and that was your butt bone that you fell on. That's your ischial tuberosity right there. The greater trochanter is often another site of bruising, but it's readily palpable there on the side of the hip. Gives rise to the Charlie horse, for example. This I should change. This is incorrect here because it says femoral condyles, and what it should say are femoral epicondyles, because the condyles, as we're going to learn later, both the elbow and the knee, the condyles are the actual articulatory surface, the surface of the joint that's lined with hyaline cartilage. The epicondyle is the peripheral region to which articulatory muscles attach. So you should be able to palpate the epicondyles on either side of your knee, and so we can see the femoral epicondyles is what that should say. The tibial tuberosity is the little prominence right there on where your shin bone comes up. It's a little prominence right there. And then, of course, the anteromedial tibia is just a fancy way of saying the shin bone. Palpate it all the way down, you have the bone pretty much exposed all the way down. The tibial condyle, again, that's really incorrect, because what we're talking about down here at the ankle, the talocrural region, are the lateral and medial malleolus or malleolus. I've heard both pronunciations, and I've given up trying to state which is right. But this is the lateral malleolus, and this is the medial malleolus. And you can see one is fibular, the other is tibial.